Thank you. I now recognize myself for questions, but I do want to take a moment to thank you all again for being here. And I will tell you, I appreciate your constructive reforms that you talk about, actions that have been taken since the pandemic response, the idea of solutions, and honest self-reflection that we all need to undergo if we are going to do better in the future. And I do hope that there can be robust work with Congress and the agencies and our federal government to do better. One of the things that we wanted to look at is the grant process. And we looked into that, and there seemed to be, from Dr. Fauci's testimony, several flaws that I think we can correct, and we can correct them together for sure, and improving the process. But part of that process is holding those that get grants accountable for their own responsibilities. So, Dr. Tabak, this past May, HHS immediately suspended and proposed debarment for both EcoHealth and Dr. Dazik. Just following up, our understanding is that this process remains ongoing at this time?
That's correct.
And does NIH still support the debarment of EcoHealth and Dr. Dazik?
We do, and we have provided all necessary documents to the department.
Thank you. At the time HHS announced the suspension, EcoHealth had 3 active grants with NIH. These grants have monies already outlaid and obligated. Does the suspension stop future funding on these grants, even if the money has already been obligated but not outlaid?
If the activity occurred before the suspension, we are by law obligated to reimburse them on a case-by-case basis. Any activities after the suspension are not reimbursable. Did
NIH make any efforts to claw back already outlaid funds, or just realized you couldn't?
This has not occurred. This is going forward from the suspension. They are not allowed to get additional funds.
Thank you. One final question for you. Dr. Dazik has routinely said that the regulations did not require that he provide NIH with lab notebooks from the Wuhan Institute of Virology. Last year, NIH put out a new rule regarding this issue. So just to clarify, when NIH asked for these lab notebooks, was Dr. Dazik required to produce them?
He was indeed.
Thank you. Dr. Wok, the select subcommittee went to Southeast Asia and Cambodia and Laos in particular, some of us, to get firsthand experience on how we work with these countries to protect the United States. And quite frankly, I find it, as we discussed yesterday, a good form of diplomacy for the United States. But while we were there, we had meetings with CDC employees that were in country. Now, you worked in global health. Do you think having U.S. government personnel in countries to try to prevent pandemics from reaching our shores has a large return on investment? And briefly, why?
Thank you for the question. Absolutely. CDC has over 60 country offices spread around the world. We have CDC staff embedded in ministries of health to work on surveillance or data collection, laboratory capability, and it's trying to help improve their workforce. So when there is a cluster of illness anywhere in the world, our staff can work closely with ministries of health to detect that outbreak and then to try to rapidly control the outbreak at its source, so that actually maintains that outbreak is maintained actually within the country or the region and never makes it to the U.S. So it's a national security asset to have these global health relationships.
Yeah, I appreciate that, and I got to see that firsthand and receive praise to the United States for our efforts in that area, and it does reduce the potential for a pandemic to reach our shores or an epidemic. The CDC issued hundreds of guidelines during the pandemic. The federal and state governments took these guidelines as a step further and imposed mandates. We had mask mandates, vaccine passports. These types of mandates blocked individuals from seeking personalized medical advice from their doctors very often. Do you think in future pandemics, ensuring the sanctity of the doctor-patient relationship is vital? Your microphone, please.
Thank you. Thanks again for the question. The COVID vaccine saves millions of lives. Related to the need for continued vaccine, I'm sorry, sir, I forgot your question, and I apologize.
I said, do you think in a future pandemic, ensuring the sanctity of the doctor-patient relationship is vital? I think that with mandates, we eliminated too much of the discussion that a patient can have with their doctor to talk about, yeah, the vaccine saved millions of lives, I'm convinced of that, but there were things it couldn't do. And patients wanted to know that, so I just wanted your take on maintaining that doctor-patient relationship.
Yes, no medical intervention, including vaccines, is risk-free. So it's very important for the patient or the person receiving that medical intervention, a vaccine, for example, have that strong relationship with their provider, so they can so they have the medical advice that they need. Some of these patients, for example, have underlying diseases or may have some complication related to the medical intervention. So that CDC makes recommendations for the population, for large communities, for communities at large, but maintaining that relationship between the provider and the patient helps interpret those recommendations for the individual.
Thank you, Doctor. Dr. Marston, in your written testimony, you emphasize the need for greater transparency within the medical product supply chain. The supply chain issue is very important to me to help prevent and mitigate drug shortages. The COVID-19 pandemic underscored just how fragile this supply chain is, as unprecedented demand led to severe shortages. Can you outline specific steps the FDA can take and maybe has started to take to strengthen supply chain resilience and prevent drug shortages during future public health crises?
Well, first I want to say I appreciate the question because these shortages are incredibly painful for communities across the country. They are not a new problem, but they certainly were laid bare during the COVID-19 pandemic. Also, it's important to recognize what's causing these shortages, and the primary causes of the shortages, the long-term causes, are these weaknesses in the markets. Right? These generic sterile injectables in particular, not everybody can make them. They need to be sterile. That's an important thing. You know this as a physician. They can't be made everywhere, and they require additional upkeep of those lines, additional care, the ability to have buffer stocks. All of these things cost money. And unfortunately, the profit margins are really razor thin. That is quite clearly beyond the mission of the FDA, but it is something where we are often trying to work on the fallout from those issues. So one of the things that we've been doing is trying to partner across government for solutions that can address those market-based issues. But for the FDA in particular, there are some things that we can do to improve our ability to prevent and mitigate shortages. First, we really need to be able to know when there's a rise in demand that these companies can't keep up with. So currently, they are required to tell us if a line goes down and they can't keep up with supply. But if there's a spike in demand, for example, as we saw with the children's analgesics a couple of years ago, they don't need to tell us about that. So that sets us back in our ability to mitigate. Second, they don't need to specify their reliance on different manufacturers for active pharmaceutical ingredients. They don't need to put those things on their label. So we have proposals that would address both of those and require that. And third, medical device manufacturers actually aren't required to tell us about any supply disruptions outside of a public health emergency. So if a tornado takes out your factory, which unfortunately is a painfully real example, you're not required to tell the FDA. We might call you, we might see it in the news, but it's not a requirement. So that's, again, something that we want to address.
Well, I don't know if you had previously read my next question, but it sounds like it. Because an idea we have had is to stand up a manufacturing reserve corps. In essence, to have trusted companies with capabilities ready to make things like mask, hand sanitizer, gowns, or vaccines, all that in place. So how can the FDA improve its coordination with manufacturers and healthcare providers to anticipate and meet surges in demand? And how can Congress help with that as well?
So maintaining those open lines of communication is one of our lessons learned from the pandemic, that early and often those communications are really what's needed to make us most effective. In terms of manufacturers, our small but mighty drug shortages staff is in close touch with manufacturers of some of these critical medical products, understanding their capabilities to make these products and be able to respond, particularly for critical medical products, should a supply disruption occur. As I mentioned, generic sterile injectables, particularly drugs like penicillin, these are things that are difficult to make, right? Not everybody can make them, so it would be important to make sure that those manufacturers are qualified and have good processes in place, don't have an issue with cross-contamination, for example, which could end up in quite a bit of damage.
Thank you.